I'm going to be talking today about the Baby-Seq Project, which some of you may have heard a little bit about before, and I'll be sure to cover some of the background as well as some of the results from the study. But what I really want to focus on today are some of the special considerations we have for this project in terms of enrollment and consent of participants. So this quote from Francis Collins back in 2012 said, "Whether you like it or not, a complete sequencing of newborns is not far away." And that being over 8 years ago now, it's still something that we don't see fully, but it's really something that's been coming along in terms of research as well as just being in the news and having a lot of public exposure. And in 2014, the NHGRI and NICHD put out an RFA to put together a consortium examining the clinical utility and the impact of genomic sequencing in newborns. And so that's how the Baby-Seq Project came to be, led by PIs Robert Green at Genomes to People at the Brigham, as well as Alan Beggs at Boston Children's, with leadership from Heidi Ream at the time at the Laboratory for Molecular Medicine, as well as the Broad, and some of our colleagues at Baylor College of Medicine, including Amy McGuire. And the Baby-Seq Project was looking at specifically at the impact of sequencing both in healthy and in sick newborns. And it was a first of its kind study, and I'll go into a lot more detail about it. But really the overarching goal was to look at the medical, behavioral, and economic impact of doing this type of sequencing in the unique population of newborns. So how does this impact their medical care now and in the future? How do parents and physicians react to this information and how do they utilize it? And what are the economic impacts? So what is the cost on the healthcare system right away and as these children grow? So Baby-Seq was set up as a randomized clinical trial of whole exome sequencing, as I mentioned, both in healthy and in sick infants. So our ICU newborns were recruited from Boston Children's Hospital, as well as the Brigham and Mass General. And then we also had the other half of our cohort being the healthy newborns, which were recruited from the Brigham Well Baby Nursery. And so for both of those cohorts, when infants were enrolled, they were randomized into our two study arms. We had our control arm, which was standard of care newborn screening. So that's the blood spot that every newborn in Massachusetts gets, as well as some version of it every newborn in the United States, looking at a panel of conditions where there's some type of treatment or actionability in the newborn period, many of which are genetic, as well as a family history from a genetic counselor. And then our experimental or sequencing arm was that same standard of care plus a genomic sequencing report. And those reports were then disclosed back to the families with a study physician as well as genetic counselor. And then the results were also passed along to the infant's pediatrician or their treating neonatologist or physician if they were an inpatient. And after the results were returned, there was our kind of outcomes measures. So those children were followed just by medical record review, as well as a whole series of surveys for parents, as well as those physicians to capture many of those different economic as well as medical and behavioral outcomes that I discussed previously. So this was not only a first of its kind study in terms of exploring doing sequencing in this very, very early period, looking at not just the presentation of health issues, say in the ICU, but also just screening in general, looking for future health risks for these children that may impact them in the newborn period, but also all the way throughout childhood and life. So it was exciting in terms of being new and being a territory that really hadn't been explored. And it was also quite complex in terms of the actual study logistics and how we would be able to go about doing this. So here's just a quick study timeline. On top, we have our parents in blue. And so the infants were enrolled typically right after birth, up to about 6 weeks of age, at which time they would have a sample collected and they would have a baseline survey and be randomized to either sequencing or the control arm. Results were then disclosed about a few months after that. The sequencing was actually done here at the Broad, and the data was then interpreted and reported by the LMM. And then those families were followed by an immediate post-disclosure survey, as well as surveys at 3 months and 10 months post-disclosure. At the same time, we were exploring the impact on physicians, be it the pediatricians or neonatologists. So when one of their infants were enrolled in the study, they had the option of participating as well in completing a baseline survey. And then they would have additional post-disclosure surveys with every infant that they had enrolled. Some physicians may have just had one infant, others may have had several. During the course of the study, physicians also had the option to order what we called an indication-based analysis. So on top of the initial whole exome, if a child were to develop new symptoms as a sick infant, or even one of the healthy infants developing some type of potentially genetic condition, they could then ask for that data to be reanalyzed with a particular focus on whatever that condition may be. And the physicians were then given a survey at the very end of the study that was linked to the baseline survey to kind of complete their participation. So the actual sequencing itself, we called the newborn genomic sequencing report. And this was a little bit different than your classic whole exome sequencing report, being that for many of these infants, this was more of a screening type of test. We weren't looking particularly to explain any presenting health conditions, because these were essentially healthy newborns in many of the cases. And what those reports were looking to report were 3 different categories. First was our kind of classic monogenic disease risk. So a genetic change, putting the infant at a high likelihood for developing some type of health condition. We also were reporting on carrier status, so just having a single heterozygous variant in a gene known to cause a recessive condition. So that would really have no impact on the child's health, but be important information for family planning much further down the line, but then also maybe more immediately family planning for their parents, many of which would be going on to have additional kids. And then the last category was our pharmacogenomic variants. So there was a small selection of those genes related to pharmacogenetic risks in childhood. And the genes themselves were carefully analyzed to kind of bin them into different categories. And this was led by Özge Bersoy at the LMM. And about 1,000 or so genes were split into these categories, so we would have some guidance in terms of what would be reported back. First would be childhood onset, strong evidence of the gene to disease association, and high penetrance, so a high likelihood that the child would actually go on to develop that condition. Then the next category kind of softened some of those thresholds a little bit, particularly the evidence and the penetrance could be more moderate if there was some type of clinical actionability for that condition or gene in childhood. What initially wasn't reported were things like adult onset, limited evidence, or low penetrance genes. A very small number of those highly actionable, well-established adult onset conditions were added to the protocol shortly after it started, mainly the BRCA and Lynch syndrome genes. But otherwise, genes with no actionability in adulthood or limited evidence were not included in these reports. On the variant level, we're reporting pathogenic or likely pathogenic changes. So not reporting benign or likely benign. We were able to report variants of uncertain significance only on those indication-based reports. So if there was a VUS in a gene that had a high likelihood of being associated with the child's presenting condition, then that could be reported. But otherwise, on the more screening results, VUSs were not included. So with this type of study, you may think, great, we have the technology, let's go ahead and do this. There's a lot of interest here. Why aren't we sequencing newborns? And those are certainly the thoughts of many people, particularly maybe in our field or here at the Broad. But there was also a lot of pushback from the community, particularly in 2015 when we started this. But even now in 2021, there's still a lot of controversy surrounding doing this type of screening, particularly in the healthy infants. And these are just a few of the ethical and IRB considerations that our team had to tackle while we were working to develop this protocol and figuring out how we would run this study. So I wanted to take some time to go through these just to give you a little bit of background in terms of how we kind of worked through them, as well as how it impacted how we ran this study. The first that we heard a lot about, and we continue, the argument often is when we think of healthy screening in infants, is child autonomy. So by doing this type of sequencing and consenting to a study, a parent is taking away the child's future decision-making in terms of their ability to decide whether or not they may want to participate in learning about a health risk or genetic health risk. And this is something that's fairly more pertinent in the healthy population. When we think of the critically ill NICU infants, it's generally more acceptable to be able to do this type of testing because the potential benefits of finding a diagnosis for a child's presenting condition generally outweigh the loss of autonomy that might come with that. But prior to that, we didn't really have that balance when we're thinking of healthy newborns or just screening for unrelated conditions. For familial impacts, we all know that genetics doesn't occur in a vacuum. For these infants, we weren't just going to be learning about them. We were going to be learning about their parents, maybe their siblings, their future siblings, and also extended family members. We did collect samples from mom and dad as part of this study. They weren't getting whole exome. This was done as proband only, not trio, but we did have samples in order to confirm particular variants found in the child. Particularly if there was a health risk associated with them, we could then go back and see if the variant was inherited from mom or dad or was de novo. Incidental and secondary findings is always a buzzword with the IRB and consent forms when we're thinking about any type of genetic testing. For this study, really almost all of what we were planning to report was going to be quote unquote incidental or secondary. That wasn't felt to explain a child's condition, maybe in some aspects with the NICU children, but it would go well beyond that. So there's the question of, are these going to be actionable results? Maybe in some cases, but we were also going far beyond that in terms of childhood onset conditions and would be reporting things that were regardless of actionability. Parental response to results is something we hear a lot about, and it's kind of, at this point, was a theoretical risk. There was a lot of concern that learning about a child's future health risk would be detrimental to a parent, that they would have increased anxiety or distress or would treat their child differently. You may have heard of something like vulnerable child syndrome. And so that was a real concern for the IRB and the community in general. Some more logistical things. We were talking about documenting things here in the electronic health record. So this was not just research testing. This was clinical testing where a child would get a CLIA certified result back and it would be put into the medical record. And once something is in the medical record, that's something that cannot really be taken out. So there's an aspect of privacy that goes along with this as well. Genetic discrimination is another category that we certainly talk a lot about in consent forms and just with genetic testing in general. Many of you are probably familiar with some of the protections that we do have. The federal law, GINA, protects against genetic discrimination by health insurers and employers. But that is not something that extends to life insurance, long-term care, and disability insurance. When we're doing testing for a child who has a condition and we're looking to explain it, this really doesn't come into play as much because they already are presenting with this condition. The genetic testing is really just explaining what's going on. But this really is something that comes to the forefront when we're talking about future risk and learning about a potential health risk for a healthy individual. We were also asking to follow these children long-term. So the active participation in the study, if you want to call it that, was more like 1 or 2 years where we would be sequencing, actively following up with parents with surveys, interviews, speaking with them. But we wanted to continue our study out or have the ability to continue it out well beyond then with medical record review or the potential to follow up with new surveys. So we could really take hold of this really important and novel cohort and follow it long term. And there's always extra considerations when you're thinking of doing something like that. And certainly not the last issue, but another important one to talk about is the vulnerable enrollment period. So we were seeking to enroll patients directly after birth. So for healthy patients, this means in the immediate postpartum period. And for those of you who are not parents, who are not familiar with kind of the postpartum period, Generally, a healthy newborn and parents are in the hospital for about 48 hours after birth before they're discharged home. Maybe a few days more if there's a C-section. So it's a very short period of time. Parents are understandably sleep deprived. Mom may be on particular pain medications. There's a lot of excitement and hustle and bustle in terms of families visiting, pediatricians needing to see the patient, OBs needing to see the mom. There's a lot going on in a very short period of time. And there's also just a lot of emotions and stress in that time period. At the same time in the NICU, you're taking all of that and then you're heightening it with a critically ill child. So there are really a lot of environmental things that we had to take into account when we're thinking about approaching families for research during this period. All right, so we're taking all those ethical considerations, we have them in mind, now we need to figure out how to address them in order to make a study protocol that was acceptable to the IRB and also acceptable to the study staff. We wanted to make sure that we were, putting out a responsible, well thought out study where we're not introducing an excess of risk. So it was really important that we addressed all of these different categories. Child autonomy is a tricky one, and I think you do your best to address that in how our protocol is written, how the consent form is written, but that's always a risk that's going to have to be maintained throughout the study, and people may disagree with. In order to combat that a little bit, it was a requirement that both parents agreed to the child's participation. So they both had to sign the consent form. If one parent did not agree, then the child became ineligible to participate. And we also have language in there about assenting the child when they're 13 years old. So getting permission from them to continue participation in the study if we're still actively collecting information at that point in time. And this goes hand in hand with the familial implications. So we were not only just consenting the parents for their child's participation, but each parent had to sign their own consent form and enroll themselves as subjects because we were collecting a sample from them and very well could learn about a health risk for them, maybe a health risk that was more immediate to them than it even was to their child. We also created something that we called our Genomic Resource Center, which is staffed by our study geneticists, neonatologists, and genetic counselors. And that was created for families and pediatricians to really assist with results follow-up. So not only answer questions about the results, but also help to further disseminate that information. So if a parent learned about a risk for cardiomyopathy in their child, that they themselves also were found to have the same variant for, we were there to be able to help in terms of directing them to a particular cardiology specialist, or in terms of speaking with their own PCP to help make that process a little bit smoother. We also, in some instances, helped with communication to a larger number of family members outside of that immediate family. All right, so the incidental and secondary findings. As I mentioned, the vast majority of what we had the potential to report was going to be unanticipated for these families. So our consent form and our consent conversation with these families required a really extensive review of the potential result types. So not only was this listed in the consent, but we also created an educational aid that had example vignettes of the different conditions. So anything from talking about a condition like Rett syndrome, where a child could be born healthy and eventually, after a couple of years of age, start to lose milestones and develop neurological symptoms. And it's a condition that right now we don't have a good treatment or cure for. So we had to talk to parents about that, make sure they understood the types of results they could get from this type of study and that they were comfortable with that. And that they could try to, encourage them to think through how they might react to that type of information. And then we also defined those result return thresholds that I shared with you earlier. So no variance of uncertain significance, penetrance limits, et cetera, taking a really careful look at actionability and age of onset and things of that nature. The parental response to results. Now, this was a tricky one. We wanted to make sure that we were measuring a parental distress to see if, in fact, the concern about parents not being able to handle this type of information was really grounded in an actual risk. So we needed to measure things like postpartum distress at all of our survey points. And we did that from some of our established scales, as well as additional questions looking at parent and child bonding and vulnerability. However, because we were asking those questions, we also had to have particular safety measures in place. So the IRB wanted to make sure that we had a plan that if you're asking a question about distress, what are you going to do if a parent does say, their responses do indicate that they are having some level of distress. And so we had a study staff psychologist, Susan Waisbrand, who was fantastic and was able to help us follow up with all of the individuals who may have been flagged. And this was in both our control and our sequencing group. The neonatal period, as everyone knows, is a really stressful time. So it wasn't unheard of for us to have individuals who did kind of cross our threshold for being needing to have someone check in with them. And then we also did something that was a first for me in terms of working with consents and protocols, and that was administering consent understanding questions. So this was something that the IRB wanted in order to ensure that parents were really on board, that they were listening during the consent session, particularly during this vulnerable period. And so there were 18 questions, true or false, that we went through after completing the verbal consent process to make sure that a parent actually fully understood what we were asking them to consent to. For EHR documentation, this was a little bit easier. It's kind of a cut and dry thing. When you have a clinical report, it goes into the medical record. So we did establish several time points for study withdrawal prior to results return, where parents knew that if they changed their mind, they could leave the study and there would be nothing in terms of results documented in the medical record. However, once they chose to actually listen to the results, at that point forward, things had to be documented. And privacy was also listed as a risk in the informed consent form. For genetic discrimination, similarly, there was a thorough review of that as a risk in our informed consent. And we were providing families with an educational aid that reviewed what GINA covered and what it didn't. And we're able to answer questions about that for them. In terms of long-term follow-up, a family was paired with a single research assistant and genetic counselor to try to maintain continuity of study contact throughout the study. So this was to try to limit confusion for families with all of these follow-up steps, make them feel comfortable, and that they had someone that they could go to with questions about the study. So the research assistant who initially approached them and helped arrange their consent session was the one who would then be following up to remind them about their disclosure visits, their surveys, asking for updates about the child's pediatric care, et cetera. And same goes for the genetic counselor, the one who performed their consent, but also be the one who'd be present at their results disclosure. And I've touched a little bit already on the vulnerable enrollment period, but a few other things that were unique to this study is that we were asked and agreed to not approach families until about 24 hours post-birth. So that even shrunk our window of opportunity even smaller to only 24 hours in some instances. But it was important in order to reduce the risks of, obtaining consent from someone who truly shouldn't be providing consent. If mom was heavily medicated or exhausted, for all of those reasons, we were bumped out for about 24 hours. And we also involved the NICU physicians and the well baby nursery charge nurses in our approach process. So once a research assistant had looked at the census, they would be reviewing all of their eligible babies with either the NICU attending or the well baby nursery charge nurse to make sure they didn't have any objections, whether that be social issues or particular health problems or really anything happening in that time period where the clinical staff felt like it wasn't appropriate to approach a family. So their permission was obtained first before we went any further. And then something that was also unique about the study was this 2-week delay. When families were enrolled, they signed their consent forms. They actually weren't considered officially enrolled in the study until they actually completed their baseline survey, which could be done anywhere between that point in time and 2 weeks later. It was once that baseline survey was completed by at least one parent that the study randomization would happen. If a family didn't complete that survey, they were considered passively withdrawn. So this just gave them a chance to go home, look through things again, think about it, and if they had any issues or concerns, they could reach out or choose not to participate. All right, so in addition to some of those logistical, ethical barriers, we had a lot of logistical barriers as well. And just a few of them are listed here. So that immediate postpartum period, as well as the ICU environment, can be very stressful. There's not a lot of opportunity for an hour to sit down with a genetic counselor to review a study consent form. And that proved to be quite difficult in terms of getting these families all the way through enrollment before they were just discharged from the hospital. The consent time commitment, again, it was not just a, hey, sign here, sign here, sign here. This is a 19-page consent form and require that a genetic counselor review the full thing with the families and review it twice if mom and dad weren't together. They each had to sit through that conversation, and that typically took at least an hour. We were asking for a blood draw from an infant who may not have needed any type of draw. This was a venous draw, not a heel stick, which was typically used for our state newborn screening. We were asking for multiple follow-up steps and return visit to the hospital. For kids in the NICU, that may not have been as problematic. They may have still been in the NICU at results return, or they may be frequently coming to the hospital for follow-ups. But for many families, their pediatric care was going to be at their community physician, and there wouldn't be a typical normal plan to come back to the hospital. And then also a continuity of care. Once we returned to these results, these kids were no longer in the care of the hospital. They were typically under the care of their pediatricians out in the community. So to combat some of those issues, we really tried our best to educate and engage the NICU and nursery staff. We wanted to make sure that they knew who we were and what our study was. So they felt like they could answer questions for their patients, or they could know who to contact if there was an issue, and just feel like they were on board with the type of work we were doing. We also created that GRC that I spoke about earlier and had that 2-week enrollment checkpoint, which was definitely a novel thing for most research. You typically sign the consent form and complete your verbal consent and you're ready to go. So this was an extra step. And we also tried to collect excess clinical sample or tack on to a clinical draw whenever possible, just to reduce the number of research-only blood draws to try to put parents at ease a little bit. But generally, particularly in the healthy population, that wasn't usually an option, and there had to be just a research-only draw. And as we started this process, it was difficult. And we found that there were a lot of hiccups and barriers along the way that made it difficult for families to enroll. And so we had to go back and revise our protocol over time. That's an important thing to know when you're working on a study, that what you lay out in the beginning, particularly when you haven't had any experience with this type of enrollment environment, you want to be able to feel like you can go back and reassess and change things. So we were able to do that several times over. We extended eligibility criteria to 6 weeks of age. Prior to that, it was a much shorter time. We allowed for remote enrollment of one parent. So if mom and dad weren't together at the bedside, we were able to consent one in person and consent the other by a phone call. We offered delayed enrollment, so they could enroll post-discharge. If a family was introduced to the study but wanted to think about it further, we allowed them to go home and complete their enrollment at a later date, should they want. And we also added remote disclosure visits. Nowadays, we're doing so many things remote, but this was pretty novel back then, the ability to return results over the phone or by video call. All right, but despite all that, enrollment was not a very smooth process. We approached a pretty huge number of patients and ended up with quite a low overall percentage of enrollment. So in the healthy cohort, we approached upwards of 4,000 babies and families. Only about 10% of those agreed to sit down with a genetic counselor and go through the consent session. Of those, about 2/3 actually ultimately decided to enroll in the study. But still, that led to about a 6% uptake rate in the well baby nursery, and just slightly higher at 10% in the NICU. So when we saw these numbers, we were quite, perplexed. We weren't sure exactly, what we could do to change this, with the IRB and with the ethical situation of the study. You had to, talk about all of these risks. It was important that the consent session covered everything, so it was going to be long. We had chosen to use the newborn period, and there were some barriers that you just couldn't wipe away. And so we wanted to really take a close look at why families were actually deciding not to participate, in the hopes that that would really educate us on future studies as to why this was something that fewer parents were interested in than we thought. I think many people on our study thought we are offering state-of-the-art, really exciting sequencing for free to families to learn about these potential health risks that maybe could be life-saving for their child. Why wouldn't you want to enroll? And what we learned is there's a lot of reasons why parents maybe weren't interested. But the first thing to note is that of those 4,000 babies, the vast majority, or I shouldn't say vast majority, but 60%, were just simply not interested in research. They may not have even heard of what our study was. It could have simply been a research assistant knocking on the door saying, "Hi, I'm here to talk to you about research. Can I come in?" And the family saying, "No, thank you. We're not interested in research." So that was quite a large chunk of those families who ultimately didn't want to sit down with a genetic counselor. So I think that really doesn't have anything to do with genetics or someone's disinterest in screening. It was more about, this kind of special time period where they were likely overwhelmed or just didn't really want to deal with another person coming into their room. But for the 30% of those individuals where we did have a reason, we looked into that further to see exactly why they didn't want to enroll. A pretty large chunk, a little over 40%, it was mostly about the study design or logistics. They didn't want to commit to coming back or being followed for an extensive period of time. They didn't want to do a blood draw, or they didn't have time to sit for an hour or so and go through the consent paperwork. But then there's also a smattering of other reasons more directly related to the study content itself, like concerns with return of results or being uncomfortable with genomic sequencing, being uncomfortable with privacy or the potential for discrimination, or being overwhelmed. And there was a difference here in those who declined the study at first approach versus those who declined a study after sitting down with a genetic counselor and going through things further. I don't think I have time today to really dive into those, but we do have a publication out that talks about that in much greater detail. All right, so the results. For this study, we found that of the 159 babies in the sequencing arm, 11% were found to have a monogenic disease risk, so found to have some type of kind of concrete disease risk on their newborn sequencing report. The 89% who were not found to have an MDR, they weren't just blank reports. The vast majority of those, I think upwards of 90%, did have at least a single carrier status variant or perhaps a pharmacogenomic risk. So this 11% was pretty substantial. And we now know that it's pretty on par with some of the other healthy screening sequencing studies that are done, like the MedSeq or MilSeq projects, where you find a decent number of individuals with an unanticipated risk. So I'll go into the details about these results, but the majority of these were completely unanticipated. So not explaining why a child was sick or in the NICU, but talking about a future risk. So we found 18 of those cases, and the genes that we reported on are listed here. And there's a big range of the types of conditions themselves, from KBG syndrome, which is an intellectual disability, and congenital malformation syndrome, to things like cardiomyopathy, familial cancer like the BRCA or Lynch syndromes, to G6PD. So there was really a great variety in the types of results we were finding, which for me as a genetic counselor, speaking to these families and returning the results, it really made me appreciate all of the time and planning and conversations that went into developing the consent form, because these families were prepared for the types of results they were getting back. due to that really in-depth consent process that was at times really tedious, but you felt as though they knew what they were signing up for, and that's certainly important. As you can see with the breakdown of these conditions, we had some where once we found the result itself, we were able to go back and actually see that the patient themselves did have some phenotypic evidence, whether that was either subclinical or not appreciated previously. We found that in 4 cases. In another almost 9 cases, I believe, we were able to identify some family history, whether that be hearing loss or parents or grandparents with heart conditions that were likely to be cardiomyopathy or history of cancer within the family. And the last kind of group were cases where it was completely unanticipated and there was no family history or no current presentation, but represented a future risk. So we really kind of found conditions and had cases all the way across the spectrum. All right, so another really important aspect here is going back to that parental response. We said we were going to be reporting on how parents handled this information and actually giving hard data to those questions about, can parents handle this information and that theoretical risk that a lot of people talked about when we started this study. So this is a bit of a busy slide, but what's important to notice here is that across all of these time points, baseline, post-disclosure, 3-month, 10-month, there was really no significant difference in the different groups we have displayed here. We have the control group, our sequencing group, and then broken out of that sequencing group, we have our individuals who had a monogenic disease risk finding, so those 18 families. And so, here we have the different cutoffs for things like parental depression or anxiety. These are established cutoffs where if scores are higher than that, there's concern for clinical anxiety or depression. And really, we didn't see that in any of our groups, and there were no significant differences between the groups or between time points. We also looked at things like parental self-blame or the perception of the parent-child relationship, so parent bonding, vulnerability, really any dysfunction in that. There's a lot of really excellent work done by our colleagues at Baylor College of Medicine to both develop these outcome measures and then analyze them as well. So there's some exciting publications that are out and that are in preparation that will go into this in far greater detail. But the take-home message is we were able to execute this study and see how parents responded, and we didn't find any significant concerns here in terms of how parents were able to react to and work with this type of information. All right. Now, another important thing to talk about here are the demographics of our enrolled participants. So this was, as we talked about, a really exciting study, but it was a lot that we were presenting to families, and our participants tended to be early adopters. And those early adopters were the vast majority white, non-Hispanic, and socioeconomically and educationally privileged. We really did not have a population that was representative of the general population in our area. And this represents a major limitation in our study and a major kind of disparity that we have in research, particularly genetic research. And so we wanted to really be able to tackle that in our future directions and try to expand this and make it more generalizable. While we got a lot of really important information and we're continuing to analyze and get important information from this cohort, there's a lot that we're missing as well by looking at this very specific demographic cohort of patients. So for our future directions, we actually have BabySeq 2 in the works, and it excitingly just received a fundable score from the NIH. And this study is going to specifically look at a much more ethnically, racially, and socioeconomically diverse group of infants. We're going to move slightly out of that kind of crazy newborn period and focus more on the 1 to 6 month range, working with community physicians and community health centers for enrollment sites. And we're working not just in Boston, but also at the Mount Sinai in New York City, and University of Alabama, and with the hope of enrolling 500 healthy infants for whole genome sequencing this time. And similar to BabySeq 1, we're going to be looking at a lot of those same outcome measures. We want to evaluate the impact of genomic sequencing on their healthcare, on their behavior, and on the healthcare economy. But we also want to do this in a responsible way with a diverse group of stakeholders and input from parents and the community to really figure out how we can create a recruitment, retention, enrollment strategy that can help us succeed in a much more ethnically and racially and socioeconomically diverse group of infants. So that was a bit of a whirlwind of all of BabySeq, all of the ethical considerations and where we want to go in the future, but it's really just the tip of the iceberg for this study. So I'm happy to answer any questions for you. I want to give a big kudos to our very large group of BabySeq team members. This is just some of them here who are working with the study, as well as all of the different organizations, including the Broad that we worked with to kind of make this study happen.
Great, thank you so much, Casie, for that really thoughtful presentation of what was such a huge undertaking. If anyone in the audience has any questions, please feel free to type them in the Q&A or raise your hand. But one of the things I was wondering about, Casie, is how you feel about kind of ongoing review of results and how you will do reanalysis. Sorry if there's a fire engine. How you will do reanalysis as new genomic data come up.
It's a great question. And it's something we thought a lot about as part of this study and have actually considered seeking additional funding for revisible reporting and being able to more regularly go back and reanalyze cases. At this point in time, we aren't regularly going back to all cases and doing a full reanalysis, mostly due to funding restrictions. But what we do have in place is when any variant that was reported for a child changes in terms of its, whether it moves from a likely pathogenic down to a VUS or something like that, the LMM is able to alert us and make a new report that we're able to give to our family members. And then we also have the continued option for the indication-based reports. So if any infants who have been enrolled in our study develop some type of symptoms, or maybe the ill infants, if their symptoms change or a doctor wants another look, we're able to go back in those cases and do a reanalysis.
That's great, thank you. I think Monica Wojcik has a question.
Oh yeah, thank you so much, Casie. Oh, that was a great talk. As you were speaking about the psych, recontact for parents who flagged high for anxiety, I was actually just thinking, I was recruiting a family to one of my studies in the NICU the other day, and the dad was like, so wait a minute, if I do this survey, you're not going to have like some psychologist call me if I answer the questions wrong, right? He's like, I did a survey for the NICU. It wasn't yours. I did a survey for a different NICU, and I said I was stressed, and next thing I know, I had the social worker checking in, and I felt a little bit trapped, and like it did seem a little sneaky. And I imagine that I don't know what study he had enrolled in elsewhere that I imagine you, with your lengthy consent process and everything, maybe there's better understanding among the BabySeq participants, but it definitely gave me pause about putting in some of these scales that will formally diagnose anxiety or depression, and then have a psychologist reach out, and then the families might feel potentially a little bit entrapped by that they hadn't been wanting to invite, a psych consult on themselves. So just to hear, obviously we need it to be safe, but just to hear your thoughts about how to do that respectfully and honestly.
Yeah, absolutely. Thanks, Monica. It's a great question. And it's definitely something that we really harped on in our consent sessions, particularly as time went on. So it was something that we did have in the consent form, that a social worker that could be part of their clinical team or someone who is part of our research team may reach out to families based on their study responses. But I would say in the very beginning of our study consent conversations, it wasn't something that I spent a lot of time talking to parents about. But that definitely shifted very early on in the study as we saw how many families were actually crossing that threshold just at their baseline survey. So likely having nothing to do with the actual sequencing or study participation, but just being at the newborn period. And so we made sure to really actually give them the heads up about that in the study consent for that very reason. You don't want families thinking that you are kind of going behind their back or talking about them in a way that they would be uncomfortable with. It's definitely something to think about for future studies.
Do you think, it might be interesting I don't know if the responses vary at all when you try to hammer that point home. I think that's the downside, is that you want people to answer honestly and not worry that they're gonna say something that will trigger psych involvement. But it seems like it wasn't as big of a problem for your population.
No, we found, and I thought about that too. You want people to answer those questions as truthfully as possible. And I was actually quite impressed by how open and honest a lot of people were with their responses. We had a lot of, people who didn't seem to be holding back in terms of how they were answering those questions, which is great. I don't know if that's something that's generalizable, and I'm sure it wasn't the case all the way through the whole, all of our study participants, but there were many people who seemed to be quite honest in their responses.